Everyone. Thank you all for joining today. It is my pleasure to welcome you to this PQI Innovation webinar titled Integrating Community and Hospital Care, Lessons from Step Up Together in Massachusetts. My name is Kaylee Espinola, and I'll be running the Zoom logistics of this webinar and introducing today's speakers. When I'm not providing tech support for PQI, I'm a senior project manager for the Massachusetts State Perinatal Quality Collaborative. A couple of housekeeping items before we begin. This webinar is being recorded and will be posted for free on the PQI website. There will be time for question and answer at the end of today's presentation, so please type any questions you have into the chat and we will address them at the end. If you experience any technical issues, please feel free to send me a private message and I'll do my best to help. Now, to introduce today's keynote speakers. The first is Amy Romano, who is a maternity care leader specializing in care model innovation, community integrated care, and quality improvement. She leads a team of consultants at Primary Maternity Care and founded and scaled up the Step Up Together program to advance perinatal safety and equity, no matter the setting. With a clinical background as a nurse and midwife, Amy is an expert in midwife-led and team-based care models, as well as the implementation of clinical and wellness programs. A prolific author and speaker on maternity care reform, Amy has developed nationally recognized quality improvement programs in collaboration with organizations such as the American Association of Birth Centers, the American College of Nurse-Midwives, the American College of Obstetricians and Gynecology, and the Institute for Perinatal Quality Improvement. Lila Foreman is a certified nurse midwife who graduated from Yale School of Nursing in 2008 and has been working in full-scope midwifery at Mount Auburn Hospital in Massachusetts ever since. Lila helps lead the OB simulation team, sits on several clinical committees, and enjoys teaching midwifery students. Lila is passionate about teaching the next generation of midwives and ensuring that more and more birthing people have access to excellent midwifery care. Lila lives in Arlington, Mass. With her husband and 2 children, both born into the hands of midwives. In her spare time, she enjoys watching her kids play sports, weightlifting, cycling, and traveling with her family. And recently, she has been able to combine her passion for teaching and travel and had the opportunity to teach master's level midwifery students in Uganda. Wow. Our third speaker today is Rebecca Skye Herman, who is the State Director for Community Birth Integration through the Massachusetts Department of Public Health funded program at the Education Development Center. A midwife and public health specialist who brings more than 20 years of experience advancing reproductive health and rights around the world, Rebecca has worked throughout the U.S., Central and Eastern Africa, and South Asia. Rebecca also serves as the current chair of the Massachusetts Board of Registration in Midwifery and has provided home-based midwifery care to the communities of Eastern Massachusetts and Seacoast, New Hampshire since 2009. Rebecca holds degrees from the National College of Midwifery, Boston University School of Public Health, Tufts University, and is a master trainer in the World Health Organization's package to strengthen health sector response to violence against women. Rebecca has been a NARM certified preceptor since 2021 and has trained midwives in Senegal, Nigeria, Tanzania, Pakistan, and the US. And now I will turn it over to Dr. Deborah Bingham, who is the CEO and founder of the Institute for Perinatal Quality Improvement. Thank you all so much for listening to our speaker intros, and we hope you enjoy the webinar.
Yeah, welcome to all of you to joining us today for our webinar. And I'm really excited to give you a little bit of updates from PQI and kind of ground us in why we are doing the work we're doing. First, the mission of the Institute for Perinatal Quality Improvement is to expand the use of improvement science in order to eliminate perinatal preventable perinatal morbidity and mortality, and also to end perinatal racial disparities. We have a lot of work to do, and we haven't made as much progress yet in the United States as we would like to. And so just to ground us all in why this matters, why we do these free webinars, why we formed PQI, just to remind you all of the US infant mortality rates. In 2022, they were 5.6 per 1,000 live births. And this is you can see this map showing the wide differences in infant mortality rates throughout the United States based on the different colors of the map. In addition, I will say, I mean, I live and work in the Massachusetts area, which has some of the lowest rates, but in different parts of Massachusetts, the rates are even higher. So there's still a lot of disparities, and this data here shows us some of those disparities, showing Black non-Hispanic infants having higher rates of infant mortality than other infants, especially when you compare to white non-Hispanic infants. In addition, we know that there is states like the state of Mississippi had just declared a public health emergency on infant mortality. They saw an increase in 9.7 deaths per 1,000 births. And in their state, the 15.2 infant deaths per 1,000 live births compared to 5.8 for white infant deaths. So it's these disparities are not unique to Mississippi. I want to be clear about that. It's just an example of how the wide differences that we need to work to address in the United States. If we look at pregnancy mortality related mortality ratios, we see the steep rise in 2020 with the pandemic. Those were mostly due to infections, but you also see the trend where we have not brought our pregnancy related deaths down enough. And we also see wide differences in perinatal mortality ratios based on race and ethnicity. And this is extremely concerning to us at the Institute for Perinatal Quality Improvement, and we know for many leaders and many clinicians throughout the United States working to address these issues. And one of the reasons we feel so passionate about this work is because we know that over 80% of these deaths are preventable. And nothing, all of us suffer when people die of preventable deaths. And those deaths are, I think, in many ways, the most tragic deaths, because it's a matter of us doing what we need to do in order to prevent those deaths. And this sentence from a recent publication really stuck out to me. They showed that during 2018 to 2022, 2,679 pregnancy-related deaths could have been prevented if the national rate was reduced to the lowest state rate. And so that gives us that's a call to action, that there is work that we could do. Other states have been able to bring down mortality rates as well. And then, and this just shows us this across the country. There's no reason, there's no special physiologic, I should say, individual reasons for why we see such wide differences across the states. It's more when you look at these data, which I do in very deep detail, we can see that it's primarily due to the practices of how birth and infants are managed and cared for throughout before pregnancy, during pregnancy, and after pregnancy. We also have seen a rise in pregnancy related morbidity rates. And all of this leads us to this very important insight that how one fares in the United States has been characterized by a racial division that begins at birth with disparities in healthcare. So with that, we have at the Institute for Perinatal Quality Improvement started the Speak Up Against Racism program. We have over nearly 2,000 Speak Up champions. And if you're not a Speak Up champion, please consider joining us in this important work. It is a unique implicit, explicit racial bias course where we use quality improvement methodology to help us develop action plans and learn and deepen our understanding of what each one of us can do to eliminate perinatal morbidity and mortality in where we live and work. We also have released a course which includes 4 modules called the Birth Equities course, and those are all available as well. We have a Speak Up modules that are also online. Other activities, as we also are expanding the use of QI methods and tools, and we offer the QI Essentials course, and the dates for 2026 will be announced later, but just keep your eye out for those conference is very popular. I've been doing those since 2018. And we have one of the leading causes of preventable morbidity in the United States is the overuse of cesarean births. And also we have underuse of freedom of movement in labor and underuse of physiologic birth. And with that, Amy Romano, who's on our panel, and I co-authored an IA intermittent auscultation simulation-based online course, and that is available for anyone in the United States, an essential skill for us as we do our work and help eliminate overuse of C-sections. We also offer these free webinars like you're attending today, and these webinars are part of our library, and you can see past presenters from this fall and earlier last year, or end of last year, I should say. The last thing I'm going to go over is, before I turn it over to our panelists, is I wanted to mention my son's book that was released in December of 2024. David, my son, died of a tragic preventable death. So we as a family are living the aftermath of what it is like when someone in your family dies of a preventable death. And he was a professor at Boston University and wrote a book, and that was under peer review at the time of his death. The book is focused in Mississippi to help us all understand how structures and context constrain people's choices, which then lead to poor outcomes, which another way of saying that is social determinants of health. And I highly recommend this book he did some very important work in Mississippi, and we're so happy that we were able to get this book finished and shared with the world. If you want to learn more about the book, we as co-editors, 2 of his colleagues from Boston University and myself are the co-editors, and the book was chosen as the book for community reads for the School of Public Health in Boston. And we did a webinar. You can also watch that webinar. I also have released a video, and I am looking to create a full documentary film about social determinants of health, and would love to have you all help contribute to making that a reality. We have a short 15-minute video that you can watch at this time. In addition, one more thing before I turn it over is I just want to say is we have this will be our 6th year, hosted a 28-day anti-racism challenge. And it's a really innovative approach to join across the country with other people who want to deepen their understanding and their work around anti-racism. And so if you register for participating, which will start on February 1st, 2026, you will get an email in your inbox, and we make it really easy for you. There's daily activities for you to reflect, to learn, and act. And we would love to have you spread the word about this free opportunity for collective action and learning. Now, without further ado, I'm very excited to turn over to Amy, Lila, and Rebecca to talk to us about integrating community and hospital care, lessons from this Step Up Together in Massachusetts. And I will say I was part of the Massachusetts one, and it was so exciting. So I'm so happy in particular to have this panel here today. So I'll turn it over to Amy now.
Thanks. I'll kick us off and then I'm going to quickly hand it off to Rebecca, who's going to go through our first few slides. But I'll just say thank you to Deborah and Kaylee for getting us started. I'm excited to talk about the work that we have been doing in Massachusetts that focuses on integrating community-based care and hospital-based care around the time of birth. So we're going to start with a lay of the land on Massachusetts and why we focus there. So as we move to the next slide, I'll hand it over to Rebecca.
Thanks so much. So honor to be here with everyone and really fun to see just the breadth of locations people are joining from. As Deborah and Amy have shared, we're really hoping to introduce everyone to sort of the how and the why of this work in Massachusetts, and also hopefully share some things that folks feel they can take and adapt and apply in their own settings. Go to the next slide. So the first question I'll ask everyone to reflect on is why community birth? For some people on this call, this may feel obvious, but particularly for folks who, whether it's through research or through clinical practice or through administration, have primarily worked in facilities and hospital settings, this question isn't always as obvious. So on the left here, we have kind of a typical labor and delivery room. You can see a nice, strong team, the partner supporting the birthing person. We can kind of see the corner there of a warmer ready for baby. And on the right-hand side, we see what birth in a community setting typically looks like. I would guess, based on the size of this tub, this is a birth center, but it could be a really nice home. And again, you see the team, you see the partner, and in this case, we can see the older sibling getting ready for baby. But if folks just want to put into the chat an observation or two about why you think families may choose community birth or how these different images speak to you, everyone can see what each other's reflections are. Yeah, great. Family-centered experience, the older child being present, really knowing everyone in the room, a lot more freedom of movement. One looks really medicalized. Yep, might be calmer. Yeah, exactly. And so often these are the things that we hear, right? For those of us who practice in community settings, many of the families who find us do so for all of the things you are putting in the chat. And what the evidence says is that with skilled birth attendants, with appropriate integration, and with appropriate access to higher levels of care when needed, it's an equally safe choice for people who enter pregnancy and sort of progress through pregnancy in a low risk context. Next slide. So, as I was starting to share, there are key pillars that the data tell us are important for safety when it comes to out of hospital birth. And this is really consistent across settings. We see this in different degrees of rurality, we see it in different resource settings. And what we know is that it's important to have eligibility guidelines and critically with that ongoing risk assessment, right? Of course, someone's risk status when they enter pregnancy isn't necessarily what their risk status will remain. And critical to understand that can move in both directions. So, on the one hand, you could have a patient enter pregnancy low risk, and perhaps preeclampsia develops in the third trimester. And on the other hand, you could have a patient who is struggling with substance use disorder at the time of conception and with appropriate support can actually progress quite far into recovery. And by the time they deliver, are in a much more stable place without substances that create risks for newborn withdrawal. Throughout pregnancy and certainly labor and delivery, monitoring remains critical, and that includes auscultation of fetal well-being and other methods for fetal well-being assessment. And then lastly, making sure that regardless of setting in terms of building or infrastructure or location, that the supplies and equipment are there to match the skill of the provider and allow for emergency treatment and stabilization should that become necessary. And you see here these referral networks and the option to transfer to a higher level of care being so essential. This is true both for community into hospital transfers, but for many of you who work in rural settings will know this is equally true for a level one community hospital, may also need this ability to transfer up to higher level of care. Next slide. So I just want to share a little bit more about the context of what we're doing and have been doing in Massachusetts for those from further afield. Many of the realities that Deborah shared, the racial disparities and other types of inequities in outcomes, both maternal and neonatal, in spite of best efforts and intentions, rising rates in disparities and poor outcomes in many cases. And in spite of having an above average number of midwife attended deliveries here in the Commonwealth, we actually ranked 32nd in the country for midwifery integration. So taken together, many of the people from all parts of the perinatal ecosystem really recognized, and we were fortunate to have our policymakers also recognizing these realities. Go to the next slide. So the road to, the momnibus or our omnibus perinatal law actually goes back really to the 1990s, but some key recent events cropped up and led to its passage and enactment into law in 2024. Key among those was the commissioning of a special report on racial inequities in maternal health, which took place in 2021. By 2022, that commission had published their findings and recommendations. It's a culmination of both literature and evidence review, as well as in-depth interviews and lived experience testimonies that really highlighted the need and the importance of improved access to choice in birth, to choice in birth provider, to access to midwifery care, and to the ability to receive care out of institutional settings as a way to help counter many of the implicit or structural drivers that people experience. Following that, the Department of Public Health and our Health Policy Commission released a separate, very related report on severe maternal morbidity overall. Many of the same trends were documented and many of the same recommendations, stressing the need to present options and alternatives to a highly medicalized, highly institutionalized system of care became apparent. And then leaning on these reports and others, Governor Maura Healey issued a state strategy and a report with several key recommendations in 2023. That combined with widespread grassroots advocacy and strong coalition efforts led to the enactment of an act promoting access to midwifery care and out-of-hospital birth options. Next slide. It is a true omnibus, and this does a lot. There are pieces in there around lactation support, perinatal mental health, increasing access to doulas, mandating Medicaid coverage for doula care, expanding access to human donor milk. So it is quite broad, but at its heart and at its center is exactly as the title suggests. And so this was really looking at how do we, from a policy standpoint, from a regulatory standpoint, reduce barriers to do many of the things that we knew were necessary, but we needed to remove some of those policy barriers. Updating regulations for freestanding birth centers, licensing certified professional midwives, mandating coverage for postpartum home visits, etc. And with that, we know that the rising rates of out of hospital birth that have been trending upwards for several years are only going to continue. And we also knew that ensuring safety and quality was equally important. And so transfer became an obvious place for us to turn our attention to in these early days of implementation and rollout of these new laws. And as a state and as a Department of Public Health, we turned to Step Up Together, who had done such fantastic work already, to begin to explore how we might begin to improve our transfer systems and our transfer relationships here. So with that, I will hand over to Amy.
Thank you. We'll go to the next slide. Oh,
Oh.
did you want to say anything?
No, there's our integrate seamless transfer of care.
There we go.
We're good.
Next slide. So I'll get into what we did, but just a little more background since I know we have folks on the call that, haven't necessarily delved into the transfer literature. Transfer rates from community birth really vary for lots of reasons. And it really depends on who the patient population is and what the overall, access in the area is. And the biggest driver of transfers is nulliparity, people having their first baby, because the most common reason for transfer are things like slow labor, and pain relief and maternal exhaustion, those kinds of things. And so emergency transfers are in fact quite rare. Only about 1% to 2% of community births involve an urgent type of transfer. More like 10 to 15% of overall births will transfer, but again, for different reasons. So, but the transfer, there's no optimal type of transfer rate. It really depends on the resources in the community and the resources and the preferences of the family. Next slide. We wanted to bring in some voices of patient experiences of transfers. These can go really, really well, and they can also go really poorly. And many people, have visceral memories and experiences, or have heard stories of, quote unquote train wrecks, which we'll get back to. But I wanted to bring in the voices of some really positive community birth transfers, and these are from a focus group we did a few years ago. People talking about feeling respect and dignity, and that they still had options and choices, even though it was difficult, that they had certain choices preserved, like delayed cord clamping or skin to skin contact, that they felt communication, they felt just that they were being cared for, is ultimately what these people were saying. Next slide. In these same focus groups, we also heard these negative comments, people feeling that treatment was punitive of their choice to pursue an out-of-hospital birth, or for other connected identities that people also have, who have, lack of trust in the system, feeling pressure to accept interventions they don't want, having fear used as a technique to get consent, and having COPS, or Department of Family, of Children and Families, called on families. That's a common event, especially again when people are Black, people are bringing identities that intersect again with their choice to have out-of-hospital birth, and it can really erupt into a really problematic patient experience, as well as a problematic experience for the staff if this is how chaotic it can feel for the families. So let's move on, because we will talk about how we're addressing some of this. The big reframe that I like to do with this program is this concept of the train wreck, that so many people who have thought about community birth have heard of this notion of incoming community births, home birth transfers are just a train wreck, meaning that it's this, incoming thing that you can't do anything about, and it's just, about to crash and there's no warning. But what we like to say is, like, in real life, when trains crash, the National Transportation Safety Board comes in, and a lot of really important work happens. And we think it's a really good framework, actually, to how to think, especially on a quality improvement webinar, about transfer. We would be gathering all of the information that we could from any source available, whether it's the conductor or the passenger or someone who observed it. We'd be analyzing all of the data, trying to understand the root cause, reporting what we could publicly so that we could, prevent these kinds of things in the future, supporting survivors, family, and people involved, staff, and advocating for change. That's what we actually do when trains actually wreck. But we talk about train wrecks in maternity care like it's something we can't do anything about or learn anything from. And so, we don't. In the case of trains, we're not saying like nobody should ever, travel by train anymore, or it must have definitely been the conductor's fault, no matter what the circumstances were, or why are you even choosing trains when there's planes and other ways to go? So I think the metaphor holds that this is the way we react to patients sometimes, and to midwives who advocate for this option when we could be looking at it as something that we could all do better to improve. Next slide. So we like to work from the 3 delays framework, which has been used really around the world in settings that have done a lot more thinking about how you move patients from the community and far-flung remote places to hospital settings for care. And you can have poor outcomes that arise in any of these 3 buckets: a problem, recognizing a problem and deciding to seek the higher level of care, problems with the actual transport itself of reaching, whether that's because of distance or just delays that can creep in. And you could also have delays that creep in after reaching the facility with teams that aren't available or people getting stuck in the ER. So we'll talk about that kind of thing. But we'll talk about the 3 delays, and we'll come back to this as I show more about what we did in the program. Next slide. So briefly, what we're trying to do with transfer improvement is improve outcomes for moms and babies. If we can reduce these delays, we can improve outcomes, and we should be able to easily kind of understand how long delays can result in poor outcomes. But we can also reduce stress for families, the healthcare team, the burnout and negative experiences this can cause for everyone when there's poor outcomes and a chaotic process. We can have better experiences that trickle beyond the transfer families themselves. We learn so much from these quality improvement experiences that trickle out through the rest of the system. We can help the hospital be a place that people that midwives are interested in making other types of referrals to, not just emergency transfers, but prenatal and pediatric referrals for their clients and other kinds of integration, and just better partnerships and teamwork for all of the care coordination and quality improvement work that we all need to do together to serve these families. Next slide. So Step Up Together is a program that we developed at my company, Primary Maternity Care, where we are focused on quality improvement in the community-based settings and in community-based care models like midwifery in birth centers and home birth settings, also in other kinds of community-based settings. We have developed tools, coaching, and a community of practice for leaders around the country that are working toward excellence and equity in all care settings. And we do it because we think care can be safe everywhere if we all just work together. So that's really built into the name, and it's what we're up to. Next slide. The core of what we do are drill kits. And so we have 12 of these. This is a close-up of one. And these are helping teams run a drill that begins in the community setting, moves by emergency transport, EMS, and ends in the hospital setting, and an interdisciplinary debrief. And we're going to hear from a team that did that in a moment. Next slide. Inside these drill kits, they each have, for each clinical topic, there's learning objectives, instructions for the person who's coordinating the drill. They're developed to run for partial or full transfer drills. So you can do what I just described of a drill that moves from one setting all the way into the hospital, or you can just drill a portion of it, the part of the emergency that happens in the community or the part of the emergency that happens, for the incoming transfer on the hospital side. You've got the clinical topic, topic and the worksheets for observers, debriefing and action guide, action planning guide, and documentation tools. So really these drill kits have everything you need to run one of these drills. And like I said, the links are in the chat. They're all freely available. Next slide. And there's the link as well. And so you can see some of the topics we have: shoulder dystocia with neonatal resuscitation, postpartum hemorrhage, first stage bradycardia are just 3 of them. And we have them for, intrapartum, newborn, postpartum, and so on. Next slide. We also include coaching from myself and the other faculty and the team that all have implementation experience doing transfer and clinical practice in multiple care settings and can think through the operational details of transfer from the community into the hospital. Next slide. And then we bring it all together with a community of practice, and we have a national action collaborative going on right now, which is our community of practice. And we pull teams together in different formations to really, so that we can do the cross-learning piece. We pull together community debrief sessions for people who are out there using these tools to run the drills to come together and say, what did you learn? What did you learn? And to share the ideas for quality improvement projects that came out of the drills. Next slide. And so this is all based on our improvement cycle for each community to sort of take on and do themselves. It starts with a process of designing a standard transfer process and standardizing as much as you can at the community level of how do you initiate a transfer? Who do you call? Where do the records go? Where does the patient go? Who can accompany them? What does the intake look like? How do they get into the into the electronic medical record system, and so on? Who's putting in the orders? Who's taking report? And there's those kinds of details. All needs to be thought through and designed. And then you can create trainings or clinical decision support tools, checklists, and so on to implement that process. And then we run the drill. So these drills are really for teams that have already been thinking about this and are ready to test a sort of desired optimal process. But no matter what you thought you've designed, you're going to learn something from the drill and realize like, oh, we could really tighten this up, or we thought it was a good idea to route the patient this way, but we really got hung up and maybe we should think about doing it this way. So lots of different ways that it could be improved upon, and then, redesigned, and the test, the loop goes around, as we all know, in quality improvement. Next slide. So in Massachusetts, what we did was we developed 2 additional drill kits, and we incorporated doula role because there was interest, and as Rebecca said, there was a portion of the legislation that focused on doula integration as well. So we have doulas can participate in all of the drills that we have, but we really emphasized that role in the 2 drill kits that we developed as part of this. We also launched a focus action cycle, which was like a loose community of practice that we had with a focus on Massachusetts teams, but we had participating teams around the country who were using the drill kits and getting some additional education from EMS leaders and hospital leaders and community birth leaders to think about implementation of the different kind of concepts and tools. We were providing technical assistance to teams in Massachusetts. We were also offering the intermittent auscultation training that Deborah and I developed. And we were bringing in national experts because we're also doing work like this in other states. And there's a lot of sort of opportunity to not reinvent the wheel and to implement best practices in Massachusetts. So over a pretty tight period of just a few months over the summer, we were really focused on doing all of this at once in a big sort of push to get some momentum behind transfer improvement around the state. Next slide. And so I want to talk now. The main thing we did, so during the summer, we had 3 teams, and we've now had a couple more who ran these full transfer drills. And so these are pictures from the drill that we did at Mount Auburn. And I just want to ask maybe Rebecca, since you're in that first picture, if you just want to talk to us about how this drill came together in the first place, and then maybe you and Lila can just walk through what's happening in these pictures. And Lila, I would love for you, since you are a clinician in this hospital, but playing the patient in it, to also reflect as you go on what that experience was like.
Yeah. So first, I think it's important for folks who may not know the Massachusetts context that Mount Auburn has one of our sort of richest and longest standing hospital-based midwifery practices. So um, in our state, those of us who sort of think about this a lot and are really focused on improving this. We had good pre-existing relationships between midwives practicing in the hospital setting and midwives practicing out of hospital setting. We had hospital staff who are already somewhat accustomed to sort of that physician midwife collaboration. And it was a really natural choice for one of our early drills. So that was, I think just important. I would say that especially folks who maybe are new to this idea and are wanting to start, um, there's enough, and anyone who works clinically in any setting knows there's enough stress and baggage around transfers. Um, that's starting with a lower stress drill, starting with sort of a lower stress group is can be really useful. Um, for logistical reasons, we got a little creative with this one. It was going to be tricky for us to do a full simulation in the way that Amy described. So we used a hospital conference room as our home setting. So what you're seeing in these pictures is we actually started with just sort of an orientation for all participants to typical community supplies. What I'm holding up in that first picture is an IV setup using a travel toiletry kit, which is often how we carry them because they can hook anywhere. You can see Lila, our lovely patient. We just sort of used conference room chairs to make a bit of a bed or a couch. So it's okay if you don't have the ability to kind of do full drill. You can still learn a tremendous amount. And then as you move to that bottom row, we transferred into labor and delivery. So you're seeing our arrival into the actual hospital setting, and then the conclusion of the drill, and then the debrief there. Yeah, Lila, over to you.
Well, I will say I was really excited to be tagged to help run this drill. I've been at Mount Auburn for 17 years, and 15 years ago, one of the doulas in these pictures had her own home birth and transferred into the hospital. And I, as her friend and hospital midwife, came to the hospital to be with her. And the culture was so different at that time. I was actually sent home by my boss because it wasn't okay for me to look like I was being any part of this home birth, which I wasn't anyway. Um, and so to do this, 15 years later, and to be acting the part of the patient with the same doula by my side was kind of felt like it really came full circle. Um, I also myself had home births. And so while I am a hospital practice CNM and have been for 17 years, the home birth space is not foreign to me. And about 12 years ago, there were three of us, three CNMs that were all pregnant and planning home births. And for those pregnancies, we were kind of it was our mission to explain to all the nurses who asked us at work, why we were doing what we were doing. So the first part of this experience that was, I think, so profound for me and the people that I was able to get involved was just bringing in hospital nurses, bringing in one obstetrician. We tried very hard to get both. The other one was not interested in spending any free time that she had. And she said that if I'm available, that's not what I want to do with my free time. Thank you. Um, so that's a project. But we did get one OB. We had a few nurses, and just being able to sit around this table and having Rebecca go through her kit and her bag of things, and talking about what community midwives bring to community births, what they have with them, what they can do, what they can't do. It was the first time that, for sure, this obstetrician and several of these nurses were sitting together with a doula, with a community midwife, and learning about what they have, and being able to answer questions and ask questions and look through the bag together was really, I think, phenomenal. The next part that I found interesting was that even though, this whole thing was planned, we knew labor and delivery was busy that day. We had reserved a room to do it. Even though it was busy, they told us we could still have the room. So, the unit coordinator knew this was happening. The charge nurse knew this was happening. We had a time that we knew it was happening. And we called up, I think it was Rebecca, as playing the role of the community midwife, called up to say, okay, we're coming up. And we went upstairs and they still weren't expecting us. So even within the drill, having told them that this was happening, the unit coordinator picked up the phone, talked to Rebecca, and still didn't tell anyone anything. And this definitely happens all the time. So they didn't know we were coming when we were coming. But they welcomed us in. And I think, of course it was acting, but I think it from there went very smoothly. And we do have one of the nurses in this picture is really a champion nurse for this cause. And she's going to sit down with me and help me kind of re-up our protocols and get a little bit of a team on board. So she acted as the nurse, and she did a wonderful job making sure that everybody felt comfortable and making sure that the community midwife and the doula could stay present with me. I was being a difficult patient, and asking for my team to not leave my side, even though I had a moderate obstetric emergency happening. And so I sort of was forcing her to play that role and to be able to take care of me and also make sure everybody was safe. I think certainly one of the biggest challenges is just having enough people to make anything happen is difficult. So putting this together that day, I only had a few people from the Mount Armored staff that were available that could help out. And even at the last minute, people were pulled away because labor and delivery was busy. And so it wasn't what we thought it was going to be. The sort of main roles like leadership and nursing was supposed to be present and then couldn't be. And then you really do need some nursing champions. You need some staff champions. I feel like I'm a staff champion. I feel like I have a personal investment in this, but not everybody does. And so it's hard to find the right people, and you need to find enough people to be able to sit down together. And I haven't even done it yet, right? I have a page of notes from this process, and I have Natalia, who's in these pictures, who's one of the nurses who's going to sit down with me. And I had another project that I was working on over the last few months, and so it's in our plan to sit down together and work out some, really just hammer out some new things on our home birth policy, which is a funny word because there's very little on the home birth policy right now.
Awesome. Well, why don't we go ahead to the next slide, and if people have more questions, you can put them in the chat or hold them. We will have some time for questions at the end, but I just wanted to share these pictures from another one of our Massachusetts drills. This was in Western Massachusetts with Cooley Dickinson Hospital and Seven Sisters, which is the one birth center that is currently operating in Massachusetts. There are a couple of others. I just love this turkey that I always have to point out that you're doing rural health when you have to wait for a turkey to cross. But it was this was a full transfer drill, including the ambulance service. And this, as you can see, or as you might be able to recognize, was a cord prolapse. And we really had to figure out how to do the ambulance transfer because they want to put somebody on the back and on their back so they can get on the gurney. And of course, the standard of care is to have the person in hands and knees. And so we had a really good little in real time kind of in service in that last photo of just really testing to see what works on the gurney, how, we were trying a couple of different ways to do hands and knees safely and talk through the logistics of patient transport. So lots of just cross learning and understanding that happened, and a lot of fun that folks had. And in that first picture, you can see the doulas as well, and they gave a lot of great feedback in the debriefs that we had, because they, really bring a different lens and focus to the experience than the clinical team members do. Next slide. So there's a lot on this slide, but we did a lot of work in a short amount of time. In this, burst of time that we were rolling this program out, we reached almost half the hospital. 41% of the hospitals were engaged in one way or in the other, either doing those drills or meeting with us to plan future drills. There's several communities that have birth centers that are being developed right now, and so we were working with those hospitals to start to map the transfer plans and to think about doing a drill in one of the, we have a couple in our current round and some that will be participating next year. And then just people inside of, like what Lila talked about, like champions inside of these hospitals, just engaging with the program in the ways that they could, even if they couldn't get, anybody else on board to plan a drill or anything. But we're trying to, just roll this out and have different strategies and ways of approaching those different hospitals, what we're starting to call our continuous improvers, the system builders, and budding champions. And so we can move on from here, because I know I want to leave some time for questions. But I wanted to just talk about some of the cross-site themes that we got. As Rebecca mentioned, some of these first hospitals were those hospitals that were already engaged in this, had some internal champions, and so we did see good, strong collaboration that was already present in these teams, and just an effort by everybody to do collaboration in real time in the drills, which was really great. We did really see a benefit to engaging doulas as part of this work, and that was a real enhancement to the program to be able to partner with Massachusetts on that. We really surfaced a lot of EMS protocol issues, some of which will need policy solutions, and definitely lots of opportunities for learning in all directions with EMS, and really thinking critically, especially as we see hospital closures and just more reliance on EMS systems for delivering more community-based care. There's a lot that we're recognizing in Massachusetts, and as we implement this around the country, that where we can improve things and come up with better systems if we collaborate better with our EMS partners. We also saw, as we heard about in the Mount Auburn, a lot of sort of hospital quality issues that came up in these drills that are not specific to incoming transfers, and that could affect a wider swath of patients, including issues with workflows in the EMR systems, transfer lines, overhead paging, getting the team where they needed to be in an emergency. And so we did see folks reflecting on just how some of these lessons learned could benefit others. And we just saw lots of opportunities to standardize and improve things, and a lot of quick things. I know that, of course, the to-do lists don't always get done right away, but even in real time, some small things can be made: adoption of a new form, or purchase of a new small piece of equipment, or just even a plan and a commitment to meet again in 6 months, and try to plan another drill in some time frame after that. Next slide. So this is just where our program is growing now. All those large numbers are where we've had lots of drills. So we are seeing, as we enter a state, we've seen a lot of growth in those states, and we have some state-based partnerships. In addition to Massachusetts, where we've worked with California and Louisiana. I'm headed out to Washington tomorrow, actually, and so we're beginning to do some work with the Smooth Transitions group out there. So we're really excited, and also to be doing more work with some of the rural states around the country. So we're really happy to see the momentum growing, and I think we just have one or two more slides, and then we'll open it up. And so this is just some of the ways that you can engage now. We have a current program that we're in the middle of, so that's a closed program right now, but the drill kit library, which one of the links it will bring you to that, is open access. And so all of those drill kits you can use and try to do a drill in your own community, even if you start with just, a partial transfer drill, or just even starting to kind of unpack it and engage with it a little bit. Next year, we're going to be having quarterly community debriefs for teams that want to continue to use these drill kits and come together in a community of practice to share out the experience. And we're going to have another kind of in-depth comprehensive action collaborative around this time next year. So for people who want to think about planning something in summer or fall next year, you can start gearing up for that now or get on our mailing list. And we also, like I mentioned, have some states where the quality collaboratives or people at the state level are engaging with the program. So there are some funded opportunities potentially for partners around the country. Next slide. These are some of our resources. I think that blog link, which itself is a big laundry list of links and resources, and the tools for Massachusetts hospitals. I really recommend that link. And then that middle item is our peer-reviewed journal article that has the outcomes of our action collaborative from last year, and that just came out a few months ago in the Journal of Midwifery and Women's Health. And I was on the Aim for Safer Birth podcast, so you should be able to just search for that and find it. And that really is talking about the relevance of this program to like some of the larger issues around system planning for transfer and rural systems of transfer. So it was a great conversation. Next slide. Rebecca, anything you wanted to add on this or where things are going for the Massachusetts work?
Yeah, I think, just really quickly, as I shared at the beginning, this is, for us here in the state, one pillar of what's going to be necessary to really expand options, and equity and access. Um, but, we're continuing to scale and grow transfer drills. As Amy shared, we've got several teams in the current focused action cycle, and additional sites who maybe aren't in this cycle, but as we head into 2026 are eager to do drills as well. Um, and concurrently, we're looking at broader quality improvement pieces through our quality improvement network at the state level. We also have emerging new variety of professional development and continuing ed opportunities so that as we identify quality gaps, we're really well placed to help, whether it's at a practice level or an individual level, sort of meet some of those challenges.
Next slide. So that brings us to the end. We only left a couple of minutes, but we are happy to answer some questions in that time. Or hand it back over to Deborah.
Yeah, thank you so much, all of you. It was really a rich discussion. And I'm just wondering if you want to just answer the question of how this idea of forming Speak Up Together came about. And then, yeah, as we close out this webinar. So, yeah.
So Step Up Together has been a program that I've been working with sort of different versions of it for many years. I used to run a network or help run a network of birth centers, kind of an investor funded effort to scale birth centers. And so we were operating a bunch of birth centers. And this was such a rich idea to centralize the function of coming up with drills, helping the teams have a standardized opportunity to run a drill. And then I think crucially to come back together and talk about how it went and then sort of accelerate the quality improvement that can happen or create an accountability structure for some of that quality improvement. So it really started with that. And then when I transitioned out of that role, the pandemic started and we had one of my first projects was to help prepare a pandemic response birth center and to think about how to get a team quickly ready to deliver babies in an out-of-hospital setting and transfer to the hospital. So that's when we started playing with it, and we've been like piloting it in different ways ever since. And now we have had some funding to kind of develop it more. And I'm really excited to partner with Massachusetts, as well as California and Louisiana, to think about how it can be part of these statewide strategies. So, yeah.
Yeah, well, thank you so much. I mean, we're now at time, but if any of you have any questions, feel free to email us at info@perinatalqi.org. And thank you for joining. We really appreciate all of your attendance, and we wish you today, as we reflect on the veterans in our lives that have helped bring our country where it is. It is a very important day to stop and reflect and thank those who have served our country. So, and all the best to all of you. So thank you. Bye.